Hello again. Welcome back to the Sunday Edition. My name is Michael Enright. In our third and final hour this morning, some of your mail in response to our special program about Emily Dickinson. The Belle of Amherst has legions of fans, as we discovered, and one of them wrote in with a poem of her own in Emily's honor. You'll hear that and more in just a little while. But first, living with pain. Dr. Michael Cousins knows about pain. Almost single-handedly, he is considered to have invented the discipline of pain management. For 40 years, he has devoted his career to the study of pain, and he has fought to have proper treatment of intractable chronic pain made available to everyone who needs it. Dr. Cousins believes that its alleviation should be considered a human right. I'll be speaking to Dr. Cousins in a few minutes from a studio in his hometown of Sydney in Australia. But before I do, I want to introduce you to someone who, in his own way, may know even more about pain than Dr. Cousins does. Sunday Edition producer Peter Kavanagh has lived his whole life in varying degrees of pain, and here, in his own words, is his story.
I am in a crib, in a hospital. I am not quite a year old. I am howling, and there is no end to the cry. It is my first memory, and the first moment of intimacy with a lifelong companion. It consists solely and simply of pain. Searing, inarticulate, inexplicable pain. It would and has marked and shaped me in ways I cannot and care not to count. Mine is not a life of pain, but it is a life in which pain has been the one constant. Witnesses have told me that the memory is true. Shortly after birth, I contracted polio. As a consequence, I have spent what amounts to years in doctors' offices, clinics, hospital beds, operating rooms, and in recovery. The result, in addition to a deep disdain for Jell-O, is a body riddled with aches and inflammation, and pain receptors and nerve cells afire with too much data to transmit. The other result is a certain sad understanding that this is how I will live out my life. The pain is real. It marks my mornings and evenings and every minute in between. And my nights and my sleep are not exempt. I have become aware over the years that I experience pain and register it even during my deepest sleeps. The pain has a rhythm and a season to it, and I understand gradations of pain the way enophiles understand subtle distinctions in vintages. I am a drafted connoisseur of the depth, breadth, and variations of pain. Pain is for me like taking a breath, as natural and as much a part of life as life itself. This, not surprisingly, has had an enormous effect on me, on the way I see the world and the way the world sees me. What I think of as a smile, others see as a grimace. When the pain is raging and I need to withdraw, others see moody, taciturn, grumpy. They are as right in their perceptions as I am in my experience. I live with pain. My loved ones live with the persona that pain and I have created. I know that at times it is not a pleasant reality, but I am at a loss as to what I can do to remedy that situation. Pain hasn't been a one-way street. It has strangely brought gifts. Pain has made me an empath of sorts. I wince and cringe as I watch others in pain. I am sympathetic to the way pain can twist the day, affect the mood. I hope and believe that I bring compassion to others. Pain has also made me perhaps more cerebral than I might have been. Pain haunts my dreams, disturbs my concentration, perhaps even shifts my perspective. But for the most part, pain is of the body, not the mind. I guess if this was a war, you might say I've ceded territory, withdrawn to my redoubt. I like to think that my pain and I have agreed to an uneasy truce. I don't take drugs. The potential side effects scare me much more than the pain does. I've seen minds and capabilities destroyed by pain medications. I'd rather keep my head and endure the pain. So I learned to cope, surround, move past, and put behind me the steep price that pain demands. I worry that it is a price too high for those around me. As I age, my moans and groans grow louder, and the effects of the latest firestorm of searing, scorching blasts of sensation grow more visible on my face, in my posture, in my movements. I know it is not easy or pleasant to witness. Someone recently observed that despite everything, I don't seem bitter. And to the extent that that is humanly possible, I agree. I am not bitter. Most religions teach us about human suffering and the degree to which suffering might be the defining quality of human existence. It is a lesson I have internalized perhaps far too well. In my accommodation with pain, let's call it a relatively reasonable accommodation, I've learned a lot about endurance, emotion, limits, and the nature of relief and the idea of small pleasures. I suppose the truly tough question is whether the education has been worth the cost. I don't know. The lessons aren't over yet. This is Peter Kavanagh for the Sunday Edition.
It was a kick to his 13-year-old nose that convinced Michael Cousins he wanted to be a doctor. He needed some surgery to put his face right again, after which he knew that medicine was his calling. But it was a doctor who was moonlighting as a professional wrestler who taught him how to work as a team player, an approach to medicine that has informed his professional life ever since. Dr. Cousins is one of the most innovative and respected pain specialists in the world. He has been in the field for more than 40 years as a clinician, researcher, educator, administrator, and community advocate. Still, he says, pain is one of the most poorly understood and undertreated conditions in modern medicine. Dr. Cousins is professor and director of the Pain Management Research Institute at the Royal North Shore Hospital in Sydney, Australia. He is the author of 3 books and hundreds of articles on pain. He developed 2 major multidisciplinary pain centers in Australia, and this fall he was influential in launching the first International Pain Summit that was held in Montreal. This morning he is in an Australian Broadcasting Corporation studio in Sydney. Doctor, good morning.
Good morning, Michael.
Pleasure to have you with us. Tell me about the doctor who was moonlighting as a wrestler and taught you about team approach. Who was that?
Well, John J. Bonica was an Italian immigrant to the USA. He arrived in America, and about a few years after his arrival, his father died. And I suppose, like me, he got a fairly early insight to the fact that he wanted to be a doctor, but he also had to try to support his family. So one of the things he did was to learn how to wrestle. He used to run across town with a couple of cement bags, one on each shoulder. And he continued wrestling during medical school, but he had to wrestle with a mask on because medical students weren't allowed to do something as unseemly as wrestling.
Of course.
So he wrestled as the masked Marvel, and he had a black mask on his face. And he eventually became light welterweight wrestling champion of the world. He was rather proud of that.
I think I remember. I remember that. What were the lessons that he taught you about medicine?
Well, I think the most important lesson was that pain is a very complex phenomenon in humans, and particularly chronic pain. And in order to be able to have some chance of managing it effectively, you needed to be able to assess the multidimensional aspects of chronic pain, and that required health professionals able to assess physical, psychological, and environmental factors that might be operating in each patient. So he gained a very early insight into this when he was called upon to look after injured soldiers immediately after the Second World War. And he realised he just couldn't do the job by himself. So that was the birth of the multidisciplinary concept of management of chronic pain. And I knew nothing about this until I met him in 1969, early 1970, when I visited Seattle. I was actually working in Montreal. I'd left Australia to work with a man called Philip Bromwich, who was a pioneer in the management not of chronic pain but of acute pain, such as after surgery and trauma.
Let's go into that question of chronic and acute. Acute pain follows a car accident or an operation of some kind, and is it easier to treat than chronic pain?
It's a little easier, but unfortunately a lot of people think the treatment of acute pain is always simple. It's not. Very often it's extremely complex. But it's also quite different from chronic pain. In acute pain, most of the time is a symptom. It's a warning that something is wrong and needs to be fixed. And if that's done, usually the acute pain goes away. In chronic pain, the situation is often different, although not always. For example, some chronic pain turns out to be due to a very severely osteoarthritic hip joint. And of course, if you replace the hip joint, most of the time, but not all of the time, the pain goes away. But a lot of chronic pain is due to a disease process in its own right. So there are changes in the peripheral nervous system at the body surface, in the spinal cord, and in the brain that represent pathology. And that pathology is what is causing the pain to continue long after whatever the initiating cause was treated.
You started out to become a surgeon, as I understand it, and then you changed your mind along the way. But tell me about these children who were burned.
Well, I was all booked up. In the days that I finished my initial intern and residency training, it was very common for Australians to go to England, and I was all booked up to go to the College of Surgeons in Lincoln's Inn Fields in London. And not long after I'd made that decision, I was rotated to a term in anaesthesia, and part of the brief of anaesthetists in those days was to look after any intensive care problems that presented themselves in the hospital. So on this particular day, I'd been alerted that some children were coming in who were extremely severely burned, and I expected them to arrive in an ambulance. So I stood just outside of the door of the emergency room, so I'd be there on the spot as soon as they came, and suddenly down the driveway leading to the emergency room walked these two little waifs. They were absolutely charred, their hair was all standing on end, and they were black all over. And these two little wailing voices came wafted down the driveway, "Save us, save us." And their parents, they were following immediately after them. I'll never forget that sight. It's just etched on my memory. So I was given the job, under supervision of course, of looking after these kids around the clock, basically, for the next 48 hours. And a very large percentage of their body was burned. They probably should have died, but somehow I managed to see them through all of this. And that made me very, very interested in the management of shock and burns and similar things. And I was told, well, the only way to do that is to train in anaesthesia and then get some extra expertise in intensive care. So that's how I went into anaesthesia, and from anaesthesia, of course, I got involved in pain.
Do we all suffer the same pain in the same way?
No, absolutely not. And this has been one of the very big hurdles to the effective management of pain. Surgeons and others early on thought that they could estimate the amount of pain that the patient should be feeling by the amount of tissue trauma. And this idea was really exploded, in fact, during the Second World War, when the first professor of anaesthesia at Harvard University, Henry Beecher, did a very simple but insightful thing. in not giving all injured soldiers an injection of morphine, but asking them first, have you got any pain? And to his great surprise, he found that a lot of soldiers with apparently terrible injuries had no pain at all. And he realised in that moment, with these observations, that there was not a one-to-one relationship between the amount of trauma of tissues and the pain experienced. And quite clearly, the experience of pain was much more complicated than that. So he made the very insightful statement, it is not the injury per se that determines the pain, but the meaning of the injury. And I think that was almost as insightful as Sigmund Freud's concept of the unconscious mind, because it alerted people to the fact that you had to look at the whole gamut of factors that might be operating in this person and impinging upon their central nervous system, and therefore changing the response of the central nervous system.
Then from Dr. Beecher's examination, from his observations, are there people who don't suffer pain, who are inured to it for some reason?
Yes, there are. There's an old condition called congenital insensitivity to pain. There's actually an abnormality in the functioning of the nerves that come from the body's surface into the spinal cord. But quite recently, almost serendipitously, it has been discovered that there was a family in Pakistan, and a little boy from this family used to perform a lot of feats in the city, putting great big needles through his arms and various things like this, and experiencing no pain at all. And then he went a bit too far. He jumped off the roof of a house and, of course, broke several limbs and had some terrible internal injuries, suffered no pain, but he died. And he was very carefully examined, and members of his family, and it was found that a single subtype of one sodium channel, the sodium channels play a very big part in the conduction of impulses along nerves. And we now know that there's not just one sodium channel, there are at least 10 subtypes, and a single one of these subtypes was deficient in this child. It's called the NAV 1.7 sodium channel, so we know exactly what it is now. In his case, a single gene was awry, and that sodium channel wasn't functioning. And because of that, his experience of pain was completely ablated. Now, that shocked me, that finding, because up until that point, we had been told, and there was a lot of evidence to support it, that there was enormous neuroplasticity.
What does that mean?
Well, that means that there's a lot of spare systems, basically. And if you knock out one of the multitude of systems, well, then other ones will take over. So it appears, however, that this particular part of the system is, there's no redundancy associated with this. In other words, there's no backup for this particular sodium channel. Now, this is a pretty recent finding, but it may well lead to the discovery of some drugs that have enormous potency and specificity. We don't know yet. It's a bit too early.
You have decided, and you want the rest of us to understand, that pain is in itself not merely a symptom, but a disease in and of itself.
Yes, Michael, there's overwhelming evidence for this now. Up until about 10 years ago, maybe 15 years ago, we had a lot of evidence in animals. But the animal models really are not totally applicable to humans. But they all pointed in the direction of changes in the central nervous system associated with persisting ongoing pain. But it was not until we started to be able to do some very clever brain imaging in patients with different pain conditions that we started to see changes in the brain that were not present in people who did not have chronic pain. And I'll give you one example. My research group for the last 20 years has been investigating pain associated with spinal cord injury. It's a terrible sort of pain. It's what we call a neuropathic pain. Patients experience shocking, burning, stabbing, pulsing sensations, and also some very nasty abnormal sensations like boiling water being poured into an open wound, or a foot that seems to be twisted into a terribly painful position. And of course a lot of these feelings are in the part of the body where there's no longer any feeling at the skin surface because the spinal cord has been injured. So we started to do brain imaging studies about the early 1990s, late 1980s, and our most recent study has shown that there are changes in the limbic system in the brain in patients with spinal cord injury and also neuropathic pain that are not present in those with spinal cord injury who have no pain. And furthermore, with those who have pain, the amount of pain that they experience is directly proportional to the degree of neuroplasticity change in the brain.
So how does that help us understand the meaning of pain?
Well, it helps us because it shows that there is actually some pathology in the nervous system, and that points to a disease process. Now, hopefully in the near future we'll also be able to examine the changes that have been seen in animals in human spinal cord. We can't do that at the moment. It's a bit too difficult. But I have no doubt that in the future methods will be developed to be able to do that. However, we have a lot of other evidence of pathology in humans with chronic pain, and this comes in the psychological and environmental domain. The clinical psychologists, those of them who are engaged in pain research, have produced enormous evidence of behavioural abnormalities, and even to the extent of severe psychiatric conditions. And of course, one of the best examples of that is depression. At least 30% of patients with chronic pain have some form of depression, often very, very high levels of anxiety, feelings of helplessness, what has been called fear avoidance behaviour, which becomes a conditioned response. Patients find that they perform a certain movement, it hurts, they stop performing it, and that goes on and on and on until they become extremely conditioned. Catastrophising, thinking extremely catastrophic thoughts about episodes of increase in pain, and many, many other conditions that have been well described and characterised by clinical psychologists. Now, this is part of the pathology of chronic pain. It causes some people to basically lose all of their life activities and to contemplate suicide. So taken together with the brain imaging changes and other changes that have been documented now, I think there's very, very strong evidence that chronic pain is a disease in its own right, regardless of what started it, which could be a very diseased hip joint with untreatable osteoarthritis. It could also be damage to the nervous system.
My guest this morning is Dr. Michael Cousins. He's professor and director of the Pain Management Research Institute at the Royal North Shore Hospital in Sydney, Australia, and one of the world's leading, foremost experts on pain and its treatment. He's in Sydney this morning. Doctor, why is it that medicine has not come to grips with the idea of pain management and pain treatment until very recently? What has held it back?
Well, two main things. Firstly, the perception that it's a very simple problem that doesn't really warrant any great attention. So just give a little morphine, if you have some. In most of the world, there isn't any morphine.
Right.
In 80% of the world, there's no access for people to morphine. But even there, it's not a simple problem for all of the reasons we've just discovered. So that's the first issue. It's been delegated to the most junior person on the team, usually to the intern, and he or she hasn't got a clue what to do. The second thing is that it has not been a priority. And one could ask, how is it that in 2010 we're discussing the fact that even for pain after surgery, cancer pain, and also particularly chronic pain, many patients are being denied pain relief?
Well,
for lots of reasons.
That raises an interesting question. A doctor once told me that when it comes to pain, the patient is the diagnostician. In other words, if I say it hurts, that should be enough.
Yes, I'll agree with that 100%. The patient is the only one who knows what is the experience of pain in that particular situation, because it's all the factors that operate inside and in the environment of the patient that determine their experience. On the other hand, since pain is so complicated, it's very difficult for patients to work out what's going on. Many of them think it's just me. It's something that I've done. It's some fault in me that's causing this horrible situation. So the biggest problem really, even right up to 2010, is that the third most costly healthcare problem in all developed countries is not a health priority. And you'd have to say that ought to be a societal disgrace. This is certainly a health problem. It's also a financial problem. It causes an incredible amount of lost income and healthcare expenses. But more than that, it's a moral issue. And I believe it should be the primary moral issue to be addressed at the present time because of the magnitude of the problem and the ridiculously long period of time that we've allowed it to go on.
I'm wondering if it's also something of a legal issue, because I know doctors who were very much involved in pain management, but the prescription of opioids to treat it, there's this feeling that, well, we can't give too much because the person might become a drug addict, or we might be charged, in fact, by the police for over-prescribing these things.
Yes, well, that is certainly a big issue, and there are lots of reasons behind the abnormal behaviour, and I think that's the best way to describe it. Those doctors, and nurses too, incidentally, are exhibiting abnormal behaviour. And the behaviour results from a number of factors, one of them being that they haven't had adequate education about opioid drugs. And unfortunately that starts all the way back at undergraduate training in nursing, in medicine, and in many, many other disciplines. It's just not there at the moment, and again, it's not a priority. But there are also cultural issues. Some people are brought up with a terrible fear of the opioid drugs, and also some very strange attitudes to pain, and that can be extremely complicated again.
Strange attitudes, meaning in some cultures that it is a sign of weakness, moral or otherwise, to admit to pain?
Yes, and also a very strong conviction that the taking of opioid drugs will lead to addiction. There's just no two ways about it. They're eventually going to cause addiction. And that develops in such health professionals a great aversion to the use of opioid drugs. Maybe it's okay in the terminal last gasp stage of terminal cancer, but in all other situations, including pain after surgery, it's really a bad thing because you'll probably get addicted. Well, that's a shocking situation to still have in this day and age, and that's why the Declaration of Montreal was one of the two major aims of the International Pain Summit in Montreal in August of this year.
But if, as you describe the situation now, it goes back to undergraduate studies, surely the people who run our medical schools must realize that there has to be some effort to put pain at the center of the education of doctors and nurses, no?
No. There's very little incentive to do that at the moment, and that's because it hasn't been made a community and healthcare priority. And it harks back really to the days when anaesthesia was first introduced in the mid-1800s. Anaesthesia could have been discovered 100 years earlier. There were some brilliant experiments by people very knowledgeable about medicinal chemistry and chemistry in general. A lot of the knowledge was there, but it just, during the Renaissance and just before the Renaissance, there was no emphasis on human rights at all. And it wasn't until the Romantic era, when the essayists and poets and others started to place an emphasis on individuality, that the environment was right for the introduction of anaesthesia. But Queen Victoria decided that she was going to have chloroform for the birth of Prince Leopold. And the professor of surgery at Edinburgh University, Professor Syme, strongly discouraged this. But she went ahead and said, I will take the chloroform. That was her statement. You go and get lost.
Sure.
I'm having the chloroform. So she had the chloroform, all went well. The Lancet then published an article that said basically, well, she didn't have the chloroform. Of course she didn't. It would have been most irresponsible for any doctor to administer chloroform, and we can state with absolute conviction that she did not have the chloroform. Well, that's the Lancet, one of the leading medical journals in the world, published that ridiculous statement. So you can get a feel for the fact that right up until the introduction of anaesthesia, it just didn't have a lot of support. And I'm afraid to say that with respect to pain after surgery, cancer pain and chronic pain, we are right where they were at the time of introduction of anaesthesia in the mid-1800s, and we need to do something about this. The community needs to get really angry, and I should tell you that the human rights organisations, and there are a large number of them, many people know about Amnesty International and Human Rights Watch and so on, but there are a lot of human rights organisations, and they're now coming together to really get behind the concept of access to pain management as a fundamental human right.
But
and that is the basis of the Declaration of Montreal.
But aside from the Declaration and the fact that it should be declared a human right, what has to happen in order to change the current approach? What if, for example, medical schools set up a separate discipline for pain education? You became a painologist or something. In other words,
well, that's all, Michael. That's already happened in some countries of the world. There are two different aspects of that. The first is at the undergraduate university level, and that has just happened in my university. I'm pleased to tell you, about 2 weeks ago, there is now a discipline of pain medicine in the University of Sydney. And I'm absolutely delighted about that. It's taken quite a few years for it to happen, but it has happened. The second thing, and this is also in Australia, is in 1999, we got the 5 key medical colleges, anaesthesia, surgery, medicine, psychiatry and rehabilitation medicine, all came together to form a faculty of pain medicine, which allows specialists in those 5 areas to do additional training. So 2 years of additional training, and at the end of that they sit an examination and they can become a specialist in pain medicine in addition to being a surgeon, physician, anaesthetist or whatever. And those 2 events I think are pivotal. Now they're happening in other parts of the world, and you'll be pleased to know they're happening in Canada. There's a move that's well underway now to develop a training program and examination in pain medicine. There are also very strong moves in Canada that I'm aware of at the undergraduate level in all health professions, not just in medicine, to have a major upswing in the content relevant to pain. And this was partly stimulated by a study carried out in Canada to compare the training of veterinarians with respect to the pain content of their curriculum with medical students. And guess what? The veterinarians were getting twice as much education about pain as were the medical students.
We recently conducted a public forum in Montreal on the question of euthanasia and palliative care, and one of the doctors on the panel said that there was no reason in the terminal stages of life for someone to suffer unnecessarily, that there are drugs and protocols and regimes now that can treat that pain so that people do not have to die writhing in agony. Is that the case?
That's only partly true. If we were to use everything that's available at the moment, we would be able to treat 90% of cancer pain and 90% of pain after surgery quite effectively. The situation with chronic pain is more difficult, but we've now moved from where I started back in 1969. We could treat about 10% of chronic pain effectively. We can now treat about 80%. But you'll see that in all three of those areas there's a very important gap, and that is there because we don't yet have a full understanding. We need a lot more research. But surely our first priority should be to apply all that knowledge and the treatments that we currently have available. And yet, that's not happening. And again, that's why I think we do need to have a human rights declaration that allows the community to give the message to our politicians. This is a priority and you must do something about it now. Otherwise we're going to languish on. We need somebody like Queen Victoria, quite frankly, to say this isn't good enough and I'm leading the way and I expect this to continue on after me. So that's the sort of thing we need. But you know, Michael, we need something else on top of that. We need to destigmatise chronic pain and cancer pain, incidentally. Patients who have cancer pain are sometimes, would you believe it, accused of carrying on about it too much.
Yeah, it's all in your head. Yes.
Abysmal for somebody with cancer.
Yeah.
But equally abysmal for someone who is suffering chronic pain every day and every night. They're stigmatised. Well, that is abhorrent in a so-called civilised world. And we need some very prominent people, former presidents of the United States, former prime ministers of Canada, who decide to take this on and finally do something about it.
I can detect in your voice and in the things you've written the frustration that you're facing, and I guess other pain doctors, pain experts such as yourself. Is there any optimism in there, in amongst the frustration?
I think there's enormous optimism now because there clearly is a human rights wave of action going on, and it's going to get stronger and stronger. There's also optimism in that we are now gaining really exciting insights into the pathology in the central nervous system that plays a key part in persistent pain. And incidentally, that knowledge is going to flow back to the management of cancer pain and acute pain. We already know now that the severity and duration of acute pain is a very powerful predictor of the likelihood of development of chronic pain. But we're also starting to get some new insights into better ways of managing acute pain to reduce the severity and duration of what we call the acute phase. So we're going to have some new treatments, and they're going to be quite different to the ones that we've had in the past. We're now talking about reprogramming the brain in people with chronic pain. So we've got all these new tools, and probably the book that puts this in context is that wonderful book, The Brain That Changes Itself, which describes the fact that the nervous system is very dynamic. It's able to change itself in response to new challenges. And one of those new challenges is severe pain. So I have enormous optimism. I probably should be retired at this stage and enjoying a well-earned rest, but I have no intention of doing that because I think the real action in this field of pain is about to happen.
Well, we join you in that hope, and I hope you do not retire for quite a while.
Well, thank you, Michael.
Thank you, Doctor. It's good to talk to you this morning. Thank you.
Bye-bye.
Goodbye. Dr. Michael Cousins is professor and director of the Pain Management Research Institute at the Royal North Shore Hospital in Sydney, Australia. He was in an ABC studio in Sydney this morning. You're listening to the Sunday Edition across Canada on CBC Radio 1 and across the United States on Sirius Satellite 137. My name is Michael Enright.
Bright morning stars are rising. Bright morning stars are rising. Bright morning
That was the Winnipeg group, the Waylon Jennies, with Bright Morning Stars.